Welcome to this program titled Driving Excellence in Amyloidosis Care, the Role of Global Centers, with the aim of really expanding the global center network of amyloidosis center. Here is the faculty. So I am a co-program director and my name is Marianna Fontana. I am a professor of cardiology at the National Amyloidosis Center, Royal Free Hospital, University College London. Co-director of the program is Dr. Vishali Sancharawala. Dr. Vishali works at the Amyloidosis Center of Boston University Copenhagen and Avedician School of Medicine and Boston Medical Center. We also have Dr. Laura Obici, neurologist at the Amyloidosis Research and Treatment Center at Fondazione Policlinico San Matteo Pavia. And finally, we have in this program Professor David Adams, University Paris Saint-Clair National Reference Center for Amyloidosis Polyneuropathy. This is the agenda. I'll start with a brief introduction of the program, and then Dr. Sancharawala will talk about unmet needs in amyloidosis diagnosis and care. So why are more specialist centers required? Then Dr. Laura Obici and Professor David Adams will talk about exploring the advantages and challenges of establishing additional amyloidosis center. And then we will talk about how we can work together to expand the global center network. And then Dr. Vishali will do a close with the main key points to take home. This is the disclosure of the educational funding for this program. So AstraZeneca and Alexion, AstraZeneca Rare Disease, have provided an unrestricted educational grant towards this independent program. And the learning objectives today are first to describe the challenges faced by patients with amyloidosis in receiving timely diagnosis and treatment. Second, recognize the necessity of global amyloidosis centers in improving diagnosis and quality of care for patients with amyloidosis. And finally, discussing the barriers to setting up more global amyloidosis centers and propose solutions to overcome them. You can submit your question to share with our expert faculty at any point during the webinar using the Q&A tab. The questions will be moderated and addressed during the audience Q&A depending on the time available. And only the moderator and the faculty will see your questions. 3 questions will now appear on screen to understand your baseline confidence and knowledge and help us measure the learning outcomes. We will revisit these same 3 questions at the end of the session and see if your responses have changed. We will also provide the correct answer at this stage. So I'll now start with a brief introduction on really the disease, the prognosis, and how it's really important for early diagnosis for our patients. This is my disclosure. So when we think about cardiac amyloidosis, we really think about 2 main types of cardiac amyloidosis. Systemic AL amyloidosis was thought to be the most common type until very recently. So in AL amyloidosis, what happens is that we have a plasma cell dyscrasia at the level of the bone marrow, which produces free light chains that then misfolds and deposits as amyloid into all the different organs and tissues. In systemic AL amyloidosis, every single organ can be involved, so the presentations can be extremely variable, and this depends really on the pattern of organ involvement. So some patients will present with predominant neuropathy, others with predominant nephrotic syndromes, or other with predominant cardiac amyloidosis. As mentioned, AL was really thought to be the most common type until very recently. And when we think about patients with systemic AL amyloidosis, cardiac involvement is present in 50 to 70% of the patients. Prognosis is really is very severe if left untreated, is less than 6 months. So systemic AL amyloidosis with cardiac involvement really present a medical emergency. Median age of diagnosis is 50 to 60 years, and myeloma may coexist, but only in 15% of the patients. So the vast majority of patients have what we call a plasma cell dyscrasia. AL cardiac amyloidosis is a reported incidence of 1 per 100,000 per year, with, we said, cardiac involvement being present in 50 to 70%, depending on the way we assess it. But recent claims data report that AL cardiac amyloidosis is really increasing from 1.5 to 4.1 cases per 100,000. The other main type of amyloidosis is ATTR amyloidosis, so transthyretin amyloidosis. This was considered a rare form, but actually is now emerging as a relatively common form of heart failure, especially in the elderly. In ATTR amyloidosis, we have a protein, transthyretin, normally produced by the liver, which misfolds and deposits into different organ and tissues as amyloid. We have two main types of ATTR amyloidosis. Wild-type ATTR amyloidosis, where the TTR gene is in its wild-type form, and patients present with a predominant cardiomyopathic phenotype, with shortness of breath being the most common symptoms of presentation. The majority of patients are really not diagnosed in life, and so it's absolutely important to raise the awareness and use the right technique to diagnose the disease. The other type of ATTR amyloidosis is hereditary ATTR amyloidosis. And here the main feature is that there is a mutation in the TTR gene. Patients can present with a cardiomyopathic phenotype, very similarly to wild-type ATTR amyloidosis, with a neuropathic phenotype. But now we know that actually most patients present with a mixed phenotype within the hereditary form, where both neuropathy and cardiomyopathy, they do coexist at the same time. ATTR wild-type amyloidosis, as discussed, is emerging as an underdiagnosed, underestimated cause of heart failure, especially in the elderly. To give you an example, wild-type ATTR amyloidosis has been reported to be present in 13% of the hospitalized older adult patients with heart failure with preserved ejection fraction with an increased wall thickness. And TTR amyloid deposits are found in more than 30% of patients with heart failure with preserved ejection fraction over the years of 75. Among patients undergoing scintigraphy, cardiac uptake was found in 1 to 3% of adults over the age of 75, and it's absolutely key to diagnose the disease and start treatment as soon as possible, because if left untreated, survival is between 2.5 and 4 years. Also, the prevalence of ATTR amyloidosis has been increased significantly. So historically, the prevalence has been described according to the predominant phenotype as polyneuropathic or cardiomyopathic, but as we said, it's really the mixed phenotype that is the most common. And now we estimated 50,000 patients worldwide. But the global incidence of hereditary ATTR amyloidosis could really be higher than initially expecting due to the non-specific symptoms which may lead to misdiagnosis and under-identification. And you will hear more about these in the later presentation. And whilst the neuropathy significantly affects the quality of life of our patients, it really presents the cardiac involvement which impacts on survival. Again, when cardiac involvement is present, the survival is between 2.5 and 4 years if left untreated. So, but then what are specialist amyloidosis centers? With growing awareness, the prevalence of patients with amyloidosis is increasing. However, early diagnosis and treatment remain challenging. Specialist centers are vital to provide quality care for complex diseases, and they provide specialized, comprehensive, coordinated, and multidisciplinary care based on current research and state-of-the-art diagnostic technologies and treatment. So establishing a specialist center can play an absolutely crucial role in improving patient outcomes for patients with amyloidosis, and this is what we will be talking today more in this webinar. Thank you very much for the attention. And now I'm very happy to introduce my co-director, Dr. Vaishali Sanchurawala, Professor of Medicine and Director of Amyloidosis Center, and she will be speaking about unmet needs in amyloidosis diagnosis and care, Why are more specialist centers required?